I will post the recording link in this today's course content folder in case anybody's power goes out or internet or anything like that happens. We will have a backup plan. I did want to talk to y'all just for a second about the plan for the rest of the week. I have been really scrambling because I really, really needed y'all in person, especially tomorrow and Friday for what we're going to be learning. Let me take a picture of this for the person who isn't in. All right. Here we go. Here she comes. Yay. All right. Okay, the gang's all here. All right. So again, I am recording this. I will post the link in today's course content folder just after the class in case you need it for future reference, or have any technical problems along the way. I do ask that if it's possible that you keep your camera on. If there is some reason that you can't, I understand. You don't have to message me. Just use your best judgment. So this is the plan for the rest of the week. I haven't changed things fully on your side of things yet, but instead of staggering the labs for tomorrow, we're all gonna meet from 1:30 to 3. It may not take us to 3. But the reason is we need to take quiz 6, and then also I have a guest presenter who was going to Zoom in anyway at 2 o'clock, and she is going to demo a very high-tech assistive technology device that I have in my office on loan from her, and I was going to let y'all play with and learn about. But instead, I will slide that in, and what else we were going to do in tomorrow's lab, I'll slide that in, and we'll just do it all on Monday in the big lab. I have a on-the-ground guest speaker coming and bring in some devices on Monday. So we'll do that all on Monday, but we're going to do some of it online tomorrow. If you have children, significant others, and or pets around while we're on Zoom, do not worry. I'm not worried about it. We are going to be super adaptable this week. Friday, we had a guest speaker coming to talk about sexual health for people with neurological disorders. You already know her. It is Dr. Janine Anderson, who guest lectured to us in Foundations, and she's back by popular demand. She, though, does not want to present via Zoom because of the sensitivity of the content. So I have moved that class to March 12th. So we will not meet for neuro aspects on Friday. Please wait to hear from your other instructors about what their plan is. We don't know that campus for sure is closed tomorrow or the next day. I just needed to go ahead and make this pivot because there were a lot of moving parts going on. Any questions about this stuff for now?
So Thursday, which is tomorrow, we're meeting in person or still on Zoom?
On Zoom.
On
Let
Zoom.
me, let me
Okay.
add that here. Yeah, I will fix that on Team Up and on the course schedule as soon as we get out of this class. I just didn't have to, like, this plan just came together about 10 minutes ago. So I'll make sure that's clear. I'll put the link for tomorrow for the Zoom on Team Up and on the course schedule like I did for today. Anything else? All right. The one other note I want to make is that when you are working in a clinical setting, whether it's on field work or when you are a licensed OT practitioner working in the field, when there is weather like this, you will be expected to go into the clinic. People are depending on you, and it is very, very rare that you get a winter weather day off as a clinician. And you just have to use your best judgment as to whether or not it's safe for you to go in, or refer to the company or facility policy. But that has been kind of a misunderstanding in the past with some students because we did some winter weather adjustments here in class, And then when they went on field work, they were surprised to find out that that wasn't an arrangement that is generally made in the clinical world. So I just wanted to mention that. But this week we are going to practice our adaptability and stay warm and stay off the roads while we need to. Um, all right. So today we're doing part 3 of spinal cord injury. If we do not finish fully this lecture content, we will have some time in the lab tomorrow to finish it. And the very tail end is about assistive technology. And so that'll kind of fit in well with what we're going to talk about tomorrow anyway. Again, we're going to be adaptable. But for now, we are going to look at the case studies. I mean, we're going to hear about those. So we have some presenters, and I'm going to call you in the order that you are listed. I'm about to pull that up on the sign up sheet. Please know though that keep your presentation to 3 to 5 minutes if you can, please, so we can stay on track time wise. I know sometimes that is hard, but do your best to, really kind of stay within 5 minutes at the most. And you are welcome to share your screen. For the couple of y'all that sent in images, I will pull that up so you can just present. And our first presenter is going to be Wesley.
Okay, hi. So I did my presentation over the movie The Upside, and the movie is about a man named Philip Lacasse who had a quadriplegic injury. Um, and it didn't state his age in it, but I would say he's around like age 50s, 60s. His wife passed away from cancer and was in need of a caregiver. Him and his executive assistant, they needed to find someone a caregiver for him, so they were doing like applications and trying to find someone. And most of the interviewees they didn't like, and then they found one that just kind of like stumbled across by accident, which in the movie his name was Del Scott, but it was Kevin Hart who was playing that character. So it was kind of funny. But Del Scott was just looking for people to sign his employment papers due to his parole officers, and he just kind of stumbled across the job. And it ended up being like both beneficial for him and Philip. But like you would have never thought that they would have been like two matches for that. But as far as his occupational profile his injury came from a paragliding accident one day when the weather was not the best and he made a bad judgment call. It doesn't mention exactly where his injury was on his spinal cord, but I'm thinking around like C6 because he was quadriplegic, and he said that he didn't have any sensation in his arms or legs and he could only move his neck. The occupations he had prior to his injury was that he writes books and he also invests in startup companies. He values his time and people he chooses to spend his time with. Performance patterns, I would say that one of the biggest things I saw was he uses his chin to navigate his wheelchair knob. So like there's obviously the caregiver there, but if he needs to get around, then he'll just like do like this with his chin and move it. And he fully relies on someone to do everything for him, like I said. But another thing he likes to do is listening to opera music when he's like going to sleep or just like getting ready or just throughout the day. He finds it very calming. His environment that, sorry, hold on. His environment that supports his occupational performance is his powered wheelchair, and that helps him get around. And then his bed is like a hospital bed that he sleeps in, and he kind of sleeps like upright more so than just like flat on his back. Um, his priorities, he enjoys socialization and listening to opera music and just writing letters. And then some challenges he faces would be like doing things on his own, he relies on everyone to do everything for him, like bathing, changing the catheter, feeding, dressing, etc. So when Kevin Hart comes in, maybe like he has no idea, like he's never taken care of anyone like that before, and he was like not wanting to help with all of that, but it was just really interesting for him to get that aspect of like that's what he has to do. Something that's motivating to him is like going for a drive. Like he likes to just like watch everything that's on the roads and stuff. Settings that he could see for OT would be home health because that's where mainly they had a PT come in the movie, and the PT was like telling the caregiver like how to do the exercises and like how to change the catheter. And So I would just say the best intervention approach for him would be to maintain his current level of function and just like maintaining his quality of life that he has right now and just like making him the best quality of life that he can and just being as comfortable as possible. Two things that should be evaluated would be his level of functioning and like what are some meaningful activities to him. Um, I would say like for me to be culturally responsive in this case would need to ask him about his culture and things that are important to him and that we could so that we could implement those into like his daily life. And then some precautions and safety concerns would just be like to knowing to for the caregiver and like all of the healthcare providers involved to just to know like how to transfer safely because in the beginning of the movie it showed like he transferred for him to the bed, but I mean from the bed to the wheelchair, but then he wasn't able to like he didn't buckle him in. So then you see like Philip almost falling forwards and like falling out of the chair. And so I would say like an adaptive piece of equipment that might be useful would be like a mechanical lift, like if the caregiver wasn't around so that he could transfer in and out of the bed. I would also ask him like if any of the doorways in his home were accessible and if he needed like ramps or anything in there. And for extra support, I would refer to him to support groups that like have people that have also gone through a spinal cord injury, just so that he could have that like similarization with someone else that's had gone through the same thing as him. And I would just ask him like what his biggest challenges that he faces in everyday life with his injury. Because I think that would just be like interesting to see and like how we could work towards that as OT. And then I chose this case because I wanted to further my knowledge with what a spinal cord injury looks like from an OT perspective. And I've seen this maybe before, like before we applied for school. So I thought that it would be cool to just do it over that. And the most important thing I learned was just that the people with this diagnosis are unable to do self-care needs by themselves and like they require full-time assistance around the clock. And the biggest takeaway I learned was just that someone with a spinal cord injury the caregivers play like the biggest part of their life in that situation. And at the end of the movie, Philip had fired Dell because of a situation he got very upset with. And then you could tell like Philip was just deteriorating and like just had lost all motivation and like didn't care about anything anymore. And so everyone tried to get him to go back to what he used to be doing and like get him to do things he used to do, but he just didn't care. And so at the end of the movie, Maggie, his PT, came and found the caregiver and was like, "You've got to go talk to him. Like, you're the only one that he might listen to." And so I would just say, like, when in the end of the movie, like you don't realize what the impact that you have on someone, especially as a caregiver, but like that's the whole like our whole aspect of OT, like the smallest impact can make the biggest impact on their life without even realizing it. So I would just say like that's my biggest takeaway.
Thank you so much. Very good. That does sound like an interesting case. Okay, next up we have Alexis. And Alexis, if you want me, if you're ready, I'll put the photo on the screen.
Okay, yes, thank you.
All right.
Okay, so I chose to do my case study on my friend Matt Hyman. So he was 20 at the time of his injury, and now he is 24. And I chose to do it on him because he's a friend of mine that I was able to see what his life looked like before the injury, and I'm able to see what it looks like currently. And I wanted to learn more about his diagnosis and get a glimpse of what his life would look like for someone who has sustained a spinal cord injury. So I'm going to kind of share a little bit about his story. So his story began in 2020 when he was swimming at his friend's house and he dove into the pool and hit the bottom, and that's where he injured himself. His friends had to carefully get him out of the water, and all he remembers is his friends praying for him. In the moment, they told him that the ambulance was on the way. He told me his friends stayed by his side all the way until the ambulance got there, and he was brought to Regional 1. Later, he was told that the injury was a spinal cord injury at the C6 incomplete level. Because this was during COVID, his parents were only allowed to be there from 8 to 8. And he told me this was really hard and he felt a lot of loneliness at the time. He was at Regional 1 for about 32 days and had 2 surgeries. He had one on his neck and the other on his back. He was flown with his medical team to Shepherd Center about a month later, and he was there for 4 months. So, like I mentioned earlier, this was during COVID, so the rules for the visitors were very strict. So his dad ended up being the one who stayed with him throughout the whole 4 months at the hospital. And the mom and brother were not allowed to see him due to the strict COVID rules during the time. So that was really hard for him. He told me that like during this time he felt a lot of loneliness and he just kind of wanted a hug from his mom. So that was something that was really, really hard for him at the time, was not having that like connection to his friends and being able to talk to his family. So yeah, so his OT while at Shepherd Center helped him learn to do things such as wheelchair to shower transfers and bed to wheelchair transfers and all the different transfers that we've learned. The OT also educated them on pressure sores and how to prevent them. She also educated him on the importance of doing skin checks so he can check for those sores. And the OT also showed his family how to check for him too, for the places he's not able to check for himself. So before he left Shepherd Center, the goal was for him to be able to know how to take care of himself and what he needed, have a bed at home that he'll be able to use, and a shower that was accessible. So prior to his injury, his occupations were working at the gym at his church, and he worked at his uncle's feed and farm store. And now he just started working at the same gym that he was working at prior to his injury. And so he's just happy to be able to get back to work again. Some personal interests he has are that he enjoys movie nights with friends and family. He also enjoys being outside. He loves to sit on his front porch and uses binoculars to look at his dogs running around the land and look at birds flying around. He also likes to go shooting, so he uses a tripod that helps hold and stabilize the gun. And he likes to play Xbox. And he told me that there's an adaptive controller that Xbox has that his OT recommended to him so that he would still be able to play his games. Some modifications that help support his occupational performance are they renovated his basement. So that's kind of like his own little apartment that they have. And he has a handicap elevator lift in it, hardwood floors, light switches that were lowered for him, different doorknobs that allow him to open the doors since he's not able to fully like grasp things. They have like doorknobs that he's able to kind of flick open and then he can open the doors. And they also have a wheelchair accessible van and portable Hoyer lift that can be used when needed. So some equipment he currently uses are he has gloves for life, which in that picture that she just showed, he had them on. So they're just kind of like this, like some gloves that he wears that help him that he's able to like maneuver the wheelchair better and a better grasp. So you can kind of see it on his hand right there. But he always has those on. He let me like feel them and they kind of have like a different pad on them, but it just lets him like hold the wheelchair better and to like turn it. He also has transfer boards, abdominal binder, a portable Hoyer lift, a regular Hoyer lift, and then he always wears compression socks, he says. So some specific challenges he faces is that insurance only gives him 20 visits a year to PT and OT, so that makes it hard for him to be able to get those services. He also mentioned that somebody always has to be nearby in case something happens. And if they go anywhere, he always has to call ahead and make sure that the place is wheelchair accessible before they can go in. So that's kind of hard for him, he says. Some precautions he has are that he's constantly readjusting himself so he can prevent getting a pressure sore. He had one early on in his injury, and he said it was the worst pain he's felt because like somebody always had to come and clean it, and he always just felt that pain. And then we've talked about autonomic dysreflexia, and that was something they were educated on too. So whenever we learned about that, I asked him about it, and he was like, "Oh yeah, like my family, like we all know about that. We know like what that would look like." So his desired outcomes is that he's excited to be working at the gym again and socializing with his friends. He wants more strength in his hands so he can have better grasp on things. He wants more accessibility in his backyard because he hasn't been able to go to his backyard since the injury. And he was like, I wonder what my backyard looks like now because he hasn't been back there. And he also would love to drive one day. So I asked him a lot of questions to see what matters to him and to hear what he values. And so if I were his OT, some goals I would have for him were for him to independently be able to open things such as water bottles and doors. I also would recommend him to an OT that specializes in driving, since that is an occupation he was wanting to do in the future. And then he also mentioned that the first floor of their house isn't really wheelchair accessible. So I would go to his house and maybe like see what modifications can be done so that he'll be able to go around his house again. And so a takeaway I had from this assignment was this assignment really helped me to see what a day-to-day life looks like for someone with a spinal cord injury. And it helped me have more empathy for people who have that injury. So that is it.
Very good. Thank you, Alexis. That I think hit on several things that are really important and relevant to what we've been talking about and learning about in regards to spinal cord injury, like leisure activities and, social connections and things like that are still so important for people after spinal cord injury, just like it is for all of us. And I know you mentioned that with the pressure sore that he felt the pain, and that's likely because his injury was incomplete. Because with a complete injury, somebody wouldn't feel the sensation. So I'm glad you mentioned that and mentioned that he was a C6 incomplete. Very
I have a question.
yeah.
Alexis, could you get a picture of his controller that's adapted? I would like to see that if you could.
Yeah. Who said that? I can't even see who's talking, but
Raven K.
Okay, perfect. Yeah, I'll ask him and I'll get a picture of that for sure.
Thank you.
Yes, that'd be real cool if you would share that with the class. I I wanted to when you said that it made me think about this. I interviewed for my podcast once an OT. Her first name's Caitlin. I can't remember her last name offhand, but she actually got hired right out of OT school by Microsoft specifically to work on making video games and other things that are accessible. And so I thought that was a really cool, non-traditional job that she got because of one of the field work she went on was at the VA hospital, and she partnered there with an OT who is himself a veteran. He calls himself the Army OT, and I had him on my podcast also. But because of their connection and what she learned and got to do on field work, she made that connection and got that cool job. So really neat. I would love to see that too. Okay, next up is Clara.
Okay, so as soon as I signed up for spinal cord injuries, Michaela Noble was the very first person I thought of because I followed her journey on TikTok and Instagram since her injury. And honestly, I've just been in awe of her grace, determination, and steady faith despite her circumstances. Until I began doing my research for this assignment, I actually assumed that her injury happened during a stunt. And because she was a flyer, it was the easy assumption and also what other social media platforms and news outlets try to convey. However, with further research and through several podcasts and interviews, I learned this was not the case. Um, Michaela Noble was a former world champion cheer athlete who suffered a severe tumbling accident in September of 2021 that resulted in a C6 spinal cord injury, causing quadriplegia and leaving her paralyzed from the chest down at only 16 years old. She was practicing a routine flip for a homecoming pep rally in her friend's backyard when her life changed forever. She says that she instantly knew that she was paralyzed. Michaela was rushed to the ER where her left lung collapsed shortly after her arrival. She was placed on a ventilator, had a feeding tube placed, and a trach inserted to suction her lungs. Once Michaela was able to breathe and eat on her own again, she began receiving rehab services. Michaela's spinal cord injury was an incomplete lesion, which we have learned means there is some preservation of sensation and motor function below the level of the lesion. She is lucky enough to have all sensation below her level of injury as well as the use of her arms. However, all of her fingers are completely paralyzed. OT services at the beginning consisted of self-care, washing her face, brushing her teeth, making cookies, and painting. Weeks into rehab, OT services were essential for Michaela to get back to her schoolwork and participate in daily occupations such as eating, brushing her hair, and socializing. To complete her schoolwork, Michaela learned to use an adaptive stylus to type on her computer, as well as utilize the talk to text feature. The same adaptive equipment was necessary for eating utensils and hair tools. OT services also made appropriate modifications to Michaela's wheelchair to prevent pressure sores and enhance social engagement, as well as provide night splints to reduce the risk of contractures. During this time, Michaela was also receiving rehab to strengthen what little she could still control of her biceps and triceps. OT services now is not documented as much. She documented a lot during the early stages of her recovery, but OT services now, if I was assuming, would focus on what is most important to Michaela, which is travel, advocacy, and strength. For travel, OT would address mobility and transfer techniques, provide airline assistance or wheelchair service information, recommend ADA compliant rooms with accessible bathrooms, ramps, and elevators, and also ensure routines are in place for medication management and bowel and bladder care routines. This is all super important for Michaela, who has traveled to Paris, Greece, New York, Mexico, California, Utah, Boston, and Indiana since her injury almost 4 years ago. Michaela also regularly participates in interviews, podcasts, and conferences to advocate for spinal cord injuries. So, OT services would address energy conservation, postural support for long periods of sitting, and social communication strategies through group discussion or building her confidence through role playing. Also, because traveling and engagement in interviews or conferences can cause Michaela to experience fatigue, stress, and muscle tension, some stress reduction techniques would also be beneficial to help her unwind after those events. Michaela is determined to maintain and gain as much strength as possible in her core and her upper extremities, and she has a personal trainer that she sees daily to achieve this. And to complement this exercise regimen, OT services would first implement strategies for safe participation in strength training while also supporting the mental and physical aspects of recovery. And second, aim to improve and adapt Michaela's daily life skills as her strength progresses. Also, because Michaela's love for sports, I thought that an outlet like the Rolling Grizzlies, like I don't know what they have available in Texas, but because she was I mean, she was a world champion cheer athlete, something like that would be really good for her as well to like bring sports back into her life. And lastly, Michaela's only wish for further home modification was that one day when she had a house of her own, she would have zero carpet because she cannot push her wheelchair over the carpet. So the biggest takeaways, really just so thankful for all the assistive technology and modern medicine and the platforms that allow people like Michaela to share their story because, like I said, I followed her since 2021 and it just reminds me like how small my problems are and just how someone like her holds herself with the grace that she has. But to conclude, I just wanted to share something that her mom said in an interview that really just kind of beautifully summarizes Michaela's story. And she just said, Michaela was a world champion cheerleader who now has the world cheering for her. So I thought that was really sweet. But in the picture, I just had the four. Obviously, it shows that was the last competition that she participated in, and then that was her in the hospital. These all came from her Instagram, and then that was her OT services making cookies in the hospital, and then that last picture was more recent on her Instagram, so of her traveling.
Thank you, Clara. That was really good. I follow her and have for a long time on TikTok too, and I love her positive attitude and also her relationship with her, I think, her younger sister. I don't know if it's older or younger, but with her sister, they really help each other out, and it's interesting to see how she gets her makeup on and does all that. I did want to mention if you're interested for anybody, if you check out, there is a cheer organization for people with paraplegia. That is paracheer.org. I just put that link in the chat. If that's just, for people to look at after this class, if you are interested in that. One thing I think we heard about when we went to the Rolling Grizzlies practice was that part of the responsibility of an OT practitioner and students are to collect information about resources in the community that we can provide to our clients and future clients to help them find their community, and kind of their thing to get back into doing things that really bring joy to them. So this could be an example for that. Next up, we have Leah B.
Okay, so the person I chose for my case study is Chris Norton. And on October 16th, 2010, Chris was only 18 years old when he suffered a C3, C4 spinal cord injury while playing in a college football game. Chris's prognosis was very dark. He was given only a 3% chance to ever move below his neck again. And at now 33 years old, Chris has defied all the odds. He has regained movement in his arms and torso and even some sensation and control from his waist down. And in 2015, Chris, with assistance, walked across the stage at his college graduation. And then in 2018, Chris married Emily Summers and once again walked 7 yards back down the aisle with the help of his now wife. And those 7 yards that Chris walked down the aisle was actually filmed and turned into the documentary 7 Yards, which is where I got most of my information from, along with Chris's website. And it's a really good documentary, so y'all should watch it. Um,
I chose this case because while sports have taken a lot of steps to reduce the risk of spinal cord injuries within athletes, it is still a very big risk factor. And I also chose Chris's story because he is one of the really rare cases that was able to defy all the odds. And I just thought that that would be really cool to research, and it was. So, for roles, occupations, and priorities of the client, prior to his injury, Chris's roles included football, studying since he was a student at Luther University, friends, and overall social life as he was in college. After his injury, his priorities shifted to family. He is now married with a wife and has 5 kids, being a motivational speaker, and his foundation for spinal cord injuries, which he started himself. So, for impact of the condition on occupational performance, basically his whole life was changed and just flipped upside down. He had to relearn how to do everything in a new adapted way. And even after years of therapy, there are some things he is unable to do. The obviously most major impact he faced was the fact that he would never play football again. And in the beginning, it was that he most likely would never walk again, but he obviously proved that wrong. This injury also had a huge impact on his mental health in the beginning. Chris was only 18 years old at the time of injury, so he had to learn how to watch his friends live the life he always imagined for himself, and obviously that is very tough. So, challenges and barriers experienced. The physical challenges he faced were obviously the loss of ability to walk and that he lost majority of some sensation from his waist down, and even his upper body is still affected. His age at the time of injury, he faced a lot of psychological challenges. He had to deal with not being like his peers and not being able to do things the same way they do. And obviously, he was faced with a lot of accessibility challenges. For instance, in the documentary, he tells a story of how one time, right after getting back to college after his injury, he went to eat with friends, and when they were transferring him in and out of the car, someone accidentally hit the lock button and they got locked out of the car. And then this just made Chris feel like a burden to his friends and obviously really embarrassed him. So the role of OT in this case would be to retrain and modify ADLs. Once again, Chris beat all the odds and progressed better than he statistically should have, but that also came with having to learn ways to do things differently. Due to his young age and prior level of function, we want to try to get him as independent as possible, especially because prior to the injury, he was completely independent. Also, we would recommend adaptive equipment for things such as a wheelchair and hygiene items to once again reinforce that independence. We will also look into home modification, make sure that if he has any stairs in his house, we can put some ramps in there and make sure that the bathroom and all that is safe. Also, given his age, we want to try to focus on community integration. Being 18 years old, getting him back into the community and back hanging out with friends and getting some positivity into his life will be a huge factor in how well he does in therapy and his attitude going into the sessions. Now that he's older, we want to focus more on travel modifications because he travels a lot for his motivational speaking events and foundation events. So the OT process in this case, in the beginning, Chris did go to an inpatient. He was there for a while, and once he was discharged, he continued an outpatient, which he still does. So those are good settings for this specific case. This is also a special case considering Chris had only a 3% chance of recovery, and he is that 3%. So in the beginning and in the documentary, they said just the primary goal was retraining ADLs, getting Chris out of bed, into his wheelchair, sitting for a couple hours of time, and just maximizing quality of life. As Chris regains movement and sensation, therapy will get more intense, more complex. He regains some control of his upper extremities, so OT will capitalize on that and work on strengthening his upper extremities and maximizing the functionality of those. Now that Chris has proven he can take a few steps, we would also focus on very, very basic gait training. He's basically learning how to walk from scratch, but in a new modified way. So we will do interventions that highlight that, and that will be very beneficial. And obviously, since Chris is continuously showing growth and continuing to improve, and he has more goals he wants to hit and makes for himself, occupational therapy is going to be a lifelong process. My big takeaway from this case was that no two spinal cord injuries are alike, which we touched on in class. Chris was a C3, C4, which is a very high level injury, but yet statistically he is doing things that by the book he should never be able to do. And this just really reinforces the idea to look at the person as a whole you were treating and not their diagnosis, because if that would have happened in the beginning, they wouldn't have believed him and wouldn't have taken what he wanted into consideration in therapy. So that's all I have.
Really good, Leah. Thank you. I think you made a really important point too at the end. Okay, last we have Rachel.
Okay, so I did my case study on Johnny Erickson Tata, and she is 75 years old and has a spinal cord injury at the C4 and C5 level. She's one of the longest living people with a spinal cord injury. So this happened when she was 17. She was involved in a diving accident. She dove in a lake where she couldn't see the bottom, and then when she was rescued, she um, didn't have any sensation in her arms and legs. Um, She was rushed to the hospital where they discovered that her spine was fractured at the C4 and C5 vertebrae, and her spinal cord was severed. So she lost movement and sensation from her shoulders and below. As for her current occupations and roles, she is a wife. She's an author, an artist, and a disability advocate. She starred in a movie about her life in 1979, which is where I got the most of this information. Um, and as of today, she has written many books and devotionals, as well as created some amazing paintings. And then she relied a lot on her faith after her injury, and it became a central part of her journey toward healing and finding purpose in life. She started a disability ministry called Johnny and Friends, which is dedicated to supporting people with disabilities. And the reason I chose her for my case study was because I volunteered at one of her family retreats for the past 8 years, which is it's a camp for families with children with disabilities. And my experiences there, what ultimately like led me to go into OT. And she also has a ministry called Wheels for the World, which they deliver wheelchairs to people in underserved countries. After her accident, she spent about 2 years in rehab. She was in an inpatient rehab, receiving both PT and OT for about a year. And during this time, she experienced a long period of depression and would ask her friends to help her like self-harm. And she struggled with the fact that she wasn't able to use her hands anymore. Um, so for Johnny and others with spinal cord injuries at this level, the use of assistive devices and modifying tasks can help them become more independent with ADLs and other occupations. For instance, the OT helped Johnny gain the ability to self-feed using a universal cuff. So because of this, it's important to maintain strength in her biceps, which is what allows her to move her arms to use the cuff for self-feeding. Um, and she also used mouth sticks, which I wasn't familiar with before this case. It's an assistive technology device that's like a stick, and one end has a mouthpiece, and it allows people to like type and or like write using their mouth. So she's wrote many books with this, and then now that technology has advanced, she uses speech to text assistive technology. And then it was also her occupational therapist that suggested that she try using her mouth to paint since art was really important to her. And she's actually created some like really cool paintings. And then another aspect of OT for someone with a spinal cord injury is home modifications. So things like ramps, walk-in showers, and roll under sinks. Some other modifications that I hadn't really thought of before doing this case study is widening doorways to fit power chairs. And then whether or not a bathroom is large enough for adaptive equipment that someone might need for showering and toileting. So unlike other neurological conditions that we've talked about, OT intervention with spinal cord injuries focuses mostly on modifying tasks in the environment to allow people to participate in meaningful occupations as independently as possible with the limited mobility that they have. So yeah.
Thank you, Rachel. That was great. I will just a little bit of a preview. We are going to make universal cuffs. I'm going to talk to you about what that is today, and then we were going to do this in tomorrow's lab, but we will do it on Monday. I have all the materials, and you can make one and keep it, and that way you can practice using it. And You'll know how to make for just like $1 a kind of DIY universal cuff if you don't have an opportunity to order one from a company or just wanted to kind of try one on the fly with a future client. You'll have that information. All right, any questions or comments before we get into what we're talking about today? All right. I will say that if you are a person who is distracted by a lot of movement, and would like to just put it where you can just mainly see the main speaker or the slides, if you go up in the right-hand corner and see view, you can drop that down and choose speaker, and it will cut out a lot of the video if you are distracted by that or if you just prefer that view.
I have a question.
Yes.
Will some of the quiz questions be over using AI for the
No,
next quiz?
yeah, no, that will not
No.
be on there. I know y'all
Okay.
are still working on that. So that will not be on the quiz. All right. So let's talk about, actually, let me fix this. There we go. Okay, so let's go on through the final part of our module on spinal cord injuries. So I want to review some of the big things that we've talked about in terms of complications. Spinal shock. So think in your head how you remember that, what you remember about it. I won't cold call on you. But remember that this happens in the first 24 to 48 hours, maybe up to a few days immediately after the spinal cord injury. And so think of it as sort of going into shock or shutting down the body in many ways, including the reflexes and even ability to do things like control body temperature and other things like that. The body needs time to reset, and the nervous system is trying to figure out what's going on. So it's not realistic to determine the level of the injury in that initial few days after the spinal cord injury because the system is in shock. Now, we talked about also orthostatic hypotension, and that is when the blood pressure suddenly drops, usually due to position change. So maybe going from lying to sitting or sitting to standing if somebody is doing that. It's a feeling of dizziness, lightheadedness, and somebody could even faint from that due to blood flow problems. And so remember for that, if the blood pressure goes down, their head goes down. So just like if someone faints who doesn't have a spinal cord injury, if you can elevate the rest of their body or at least their lower extremities above the level of their head, that's going to help blood flow go back to their head and help that kind of resolve. Now, much more of a medical emergency is autonomic dysreflexia. And I like that some of the case studies really touched on this, and we've talked about this now 3 times in lecture. This is a potentially very dangerous and even life-threatening emergency that is a reaction when the blood pressure suddenly gets too high due to something that is irritating or going on elsewhere in the body. So it might be a full bladder, constipation, a splinter, tight clothing. We talked about maybe an ingrown toenail, something like that. And what it feels like is a pounding headache, sweating above the level of the lesion, flushed face. And remember with that, if the blood pressure goes up, the head goes up, and then you are going to check the blood pressure again, check the body, try to figure out what's going on. If the blood pressure is still persisting, you need to get the person more medical attention. On the bottom row, we have a decubitus ulcer, also known as a pressure sore. This is when pressure builds up in a very specific part of the body due to sustained pressure on that area. Usually it's on a bony area like the hip bones, the tailbone, the heels. And this is due to compromised circulation that comes after spinal cord injury, as well as an inability to feel and move within their own body, so the person with a spinal cord injury doesn't shift their weight or their position regularly like we do. So that can be not only uncomfortable if someone does happen to have sensation with an incomplete injury, but it potentially could be very life-threatening because it's an open place that can get infected, and that infection can enter either the bone and or the bloodstream, and the person can go into septic shock. Next is edema, and that's just a fancy word for swelling, for fluid that is collected underneath the skin. It can get quite large over time and cause pressure on the skin and even the internal body parts. Usually this will be in the legs and feet, and it's again due to poor circulation as well as compromised sensation and motor skills. So what might help with that is movement, stretching, even elevating the legs, positioning. And last on the list is the deep vein thrombosis, or in a medical chart, you may see that as a DVT. That's when a blood clot forms in a deep vein, usually in the lower extremities. And that happens again due to poor circulation, sensation problems, movement compromise. So a lot less activity would put the person at risk for this. Now, the biggest complication or risk associated with the DVT is if that blood clot breaks free from the lower extremity and travels to the heart, the lungs, or the brain, where it can obstruct blood flow and oxygen supply to those parts of the body. So, wearing compression garments, compression stockings could help with that, as well as movement, and sometimes even medications would be recommended by the provider to help avoid that. So all this to say that these complications can be serious. They are not uncommon for people with spinal cord injuries, and that's something you really need to know about. But with the right care and precautions and awareness of when further medical attention would be needed, it's very possible to live a long life in a way that is healthy and productive after spinal cord injury. So let's get into talking about the different levels. What function is available at what level of spinal cord injury? And I want to point out that I'm talking about complete spinal cord injuries, although even with incomplete injuries, you will generally see the majority or potentially all of these problems. So we're going to focus on some of these in sections, and rather than individual levels all the way down the spine. And we're going to really focus on function. So these are the things you need to focus on in terms of entry level practitioner spinal cord injury knowledge and what you need to know for this course. So at the very highest level of the neck, C1 through C3, so that's very close to the head, that's considered a high-level spinal cord injury, high-level tetraplegia or quadriplegia. And the person will have only limited movement of their head and neck, and even that will be very weak. They will require a ventilator and will have a trach in their neck where the ventilator is attached. Communication would be possible with assistive technology. And so that would generally be potentially voice-controlled devices, but most likely eye tracking systems. And in our lab on Monday, you will get to try out an eye gaze activated communication device. So you'll see what that looks like and what it feels like to start to use one of those. At this high level, a person is dependent in all activities of daily living, including eating, dressing, and mobility. Next down is the C4 level, and this would still be a tetraplegia level or quadriplegia. The paralysis would still affect their neck, head, and down, including the trunk, upper and lower extremities. Note that at this level, the person is still unable to cough productively, and so they would need some assistance through suctioning and positioning and medication to help control their oral secretions. Now, as compared to the C1 through C3 level, at C4, the person will have slightly better head and neck control and strength, and some shoulder movement may be possible, and that would be in the trapezius, although that will be very weak. Breathing support at the level of C4 will require at least intermittent ventilator support. If you remember when I talked about the Tulane football player that my daughter went to school with, this was his level, and so he could occasionally pause the use of the ventilator, but generally needed that for proper oxygenation. At level C4, the person will be dependent in ADLs, but they may use some adaptive equipment for communication and mobility. So, in other words, they may be able to control a powered or electric wheelchair with head controls because they've got a little bit better head movement and strength and the trapezius movement. Lizzie, did you want to chime in?
Okay, good. That worked. I was like, I don't know if she's gonna see this.
Yeah, pops up on my screen, so that works well. To raise your digital hand.
Okay, good. I just wanted to ask about the intermittent ventilator support with like a respiratory therapist. Could he gain more function or like not him, but like any could they gain more function and like control of like their lungs and breathing and like eventually need the ventilator like less and less? Is that possible to like strengthen those muscles
That's
even
a
with
good
an
question. Early on, possibly.
Mhm.
But beyond the period of a few months after the injury, it's very unlikely if it is a complete injury. If it's
Okay.
incomplete, the game is changed. And then, yes, depending on how much is of the spinal cord is severed or damaged, they may be able to, but they will not at level C4 complete have innervation of anything below the trapezius muscle. So no respiratory support muscles like the intercostals. Does that make
Got
sense?
it.
Okay.
Yes, they
And Mary Dryer, do you want to chime in?
Yes, I just have a question. So my cousin has the C2 spinal cord injury,
Mm.
but he is able to like talk, he can move his hands, he's not on a ventilator, like he can even eat. So is that because of the age he was when he sustained his injury and that he was just since he was really young, he was able to like have some form of neuroplasticity in his upper extremities or like how
No.
exactly would that
So in
differentiate
short,
between?
no, his injury must be incomplete.
Okay.
But that brings up a good point. While we talked about with acquired brain injuries that there is that neuroplasticity possibility, that is not a possibility in the spinal cord. There's just not
Okay.
as much real estate. There's just the spinal cord innervation tracts.
Mhm.
Um, so there's not rerouting that's possible with the nerves in the spinal cord. So his injury must be incomplete, which again is a fortunate thing, all things considered, because that's really good function for somebody with that high level. All right, so let's keep going. Next, we'll talk about C5. Now, at this level, still high in the neck, but at this level, the person has good head, neck, and shoulder movement. They even have elbow flexion. So I always kind of do that as I say it to help me envision the function. So elbow flexion and forearm supination present, but no elbow extension or hand function. And with pronation, it's just generally gravity assisted, but then they can functionally flip their forearm back over. So it's palm up. At the level of C5, The person can generally breathe on their own, but they may require a lot of breaks, and that may be pretty fatiguing for them. They can use a power wheelchair with hand controls instead of a head control, and they then can generally do moderate assisted ADLs overall, especially with things that aren't quite as physically demanding, like feeding themselves and grooming. Next is level C6. With this one, what is available that's very important is wrist extension. So remember, we talked about that in our last talk about spinal cord injury because that relates to a function called tenodesis. You have to extend your wrist to get that hand closure. You don't have to flex it, and because flexion is not available at C6, but gravity pulls it down. That's not voluntary. And no elbow extension. Still elbow flexion. All the things in the levels above C6 that we already talked about, like elbow flexion, supination, but also wrist extension there. So at the level of C6, the person can use a manual wheelchair with adaptations to help them grasp, as you saw in one of the case studies. Now, they might still have a power chair because of the fatigue that it happens with that so much effort required to self-propel. But it's very handy that they can have a manual wheelchair because that is much easier to transport in a vehicle and to bump up curbs and things like that because it's much, much lighter weight than a power chair. At level C6, usually with adaptive equipment, including a universal cuff, which I'm going to talk to you about more, the person can independently perform some ADLs like feeding, grooming, possibly even dressing their upper body with rehab, with teaching for that and with assistive devices. The person at C6 can help with transfers, but typically needs help transferring from one level surface to another. So if the bed is higher and they're going a little bit downhill to the wheelchair, they may need a little extra help. Certainly, if they're going uphill, like from a lower surface to a higher surface, they're going to need some help because even with those movements, they still don't have great strength. Any questions or additional comments about that so far?
I was just wondering, how are people raising their hand? Just in case I need it.
Yeah, that's a good idea. We should talk about that. Let me see here. I'm looking at mine. Anybody who has raised their hand want to comment on that?
It's
You
in
go
the
to
it's in the React, like on your like participants chat, React, share apps. There's the React and you click it and it's like the little heart and you do raise hand.
Thank
And
you.
then when you want to turn it on, it'll pop up and it'll say lower hand.
Awesome. Thank you.
Okay, thanks,
I
Lizzie.
do have a quick question, Dr.
Yeah,
Lancaster.
sure.
So for my case study, I didn't know the exact level of injury, and I was kind of just assuming it was around a C6, but I was assuming it was a complete injury. But if by looking at that, I don't think that's correct. What level of injury do you think that it was with because he was only able to move his neck? So probably like C2 maybe.
Yeah, possibly. It could have be maybe C3.
Okay.
And it's so much harder to predict the level or guess it if somebody is incomplete because they would have spotty skills that are gonna go down into the levels below. But if the person cannot really move their neck, it probably is C2 or 3.
Okay, thank you.
Leah,
I was gonna ask, how can someone with a C5 injury, like with a power wheelchair, use hand controls? Like what kind of hand controls would they need in order to
that's a
use
very
it?
good question. I can tell you're really thinking and picturing in your head what their hand function is going to look like. So it's going to be a lot sort of like a joystick or a knob. That is you almost could do it, just with the I guess, the base of your wrist in your palm, where you're just kind of shoving it over one way or another. Not even really grip strength is required for that. So that's really with the power wheelchair, how that would happen. Anybody else?
Oh, Dr. Lancaster, I did have a question about
Yeah.
the C5 injury. So since you said they have elbow flexion but not extension, would that be a case where they'll have a lot of contractures? Would that be, or
Typically not, because they probably will have very a lot of flaccidity, so not tightness in their hands. And if you see somebody, and I'm going to show you some videos today, and really notice their hands, because that is the best predictor really of what their level is. And then if you notice their hands, and they seem fine, you can kind of observe from down there. But you really, if you notice that at level C5, actually they don't have wrist extension at C6 either, but gravity is going to pull them into those positions unless they power against it.
thank you.
Thanks for asking that. Raven, what you
For the C4, where it says the intermittent ventilator support, would they still have a trach like for that intermittent or like
most almost for sure.
okay.
Early in their injury, if you're like looking up stories or you come across somebody, or if you work with a patient, the trach tube may go, the ventilator tube may go in their mouth. But because that causes a lot of irritation, and it's just not a long-term solution. So like if you have surgery and you have to be, put all the way to sleep, they'll put the breathing tube down your throat through your mouth, because it's very temporary. But after a week or so of somebody being on that, their mouth is going to get really irritated and dry because it always is open. So they would recommend a trach for that.
So how would the intermittent part work if they had a trach?
Okay, I like that I can tell you're picturing the way that works. So usually, so they would have, there is a trach tube that comes out that's different from the ventilator tube. It holds the airway open. So imagine it's not this wide, but imagine it almost kind of like a toilet paper tube, the cardboard part. And that stays in their windpipe or their trachea. Now the ventilator tube can go down in there, but it also can come out, and still they'll have that trach tube. And so if they take the ventilator out, they can put a little valve over it. It's called a Passy-Muir valve. It's just like a little plug that has some tiny holes in it that keeps anything that doesn't need to go down their trachea, it from doing it. It also helps close it off partially so that they're able to make some vocalization that way. So it's if you look at videos, or when you're out in the field, when you see people with that, this will all make more sense. But hopefully you can picture it a little bit. It's two different tubes. One fits in the other one and can come out. The trach tube itself stays in place.
Thank you.
Good questions, you guys. All right, so we talked about 5 and 6. Let's talk about C7 to C8. Now, it's usually written as C7, C8, because even though they're just 7 cervical vertebra, because the spinal cord just below the 7th vertebra is really considered the C8 spinal cord level. I think we watched a video and they talked about that, but think of C7 and C8 as essentially the same. And this is the most common level of spinal cord injury. Probably because if you feel in the back of your neck and you feel the low down on your neck, the bone that sticks out right there, that's C7. So it's a bony protuberance and very easy to have a break, a fracture right there that can then cut into the spinal cord itself. So many times when you're looking at people's hands, trying to think to yourself what their level might be, you kind of C6, C7, 8, that's going to really be on your mind by looking at their hand function. So at this level, the person would have full elbow movement and even some weak finger extension. They would have strong wrist extension, so they can use a universal cuff. They can use tenodesis functionally, whereas at the C6 level, they can perform tenodesis, but it's going to be really weak. So if they're going, like, here's a full bottle of water. If I'm at C6 and I'm trying to use tenodesis to pick this up, it's very likely going to slip through my fingers. It's just too heavy. Now, I could probably pick up a paper towel with tenodesis. Or if I have a universal cuff on a strap around my hand and something is put in the pocket of that, that would be fine at C6. But at C7 and 8, I will have a strong wrist extension, better grip strength, but still the power is a little bit limited. The person can use a manual wheelchair more effectively. They will have independence in ADLs with adaptive equipment, including dressing, eating, and grooming. They can assist with or independently perform all transfers and may be able to drive if a vehicle is correctly adapted in a customized way. So, couple of big new things at this level, one being strong tenodesis, and the other being the potential to drive an adaptive vehicle. Cabrina, did you want to add to this or chime in? You might be muted. I saw you raise your hand.
Ah, there we go. It wasn't working. Got it. I do have a question. The picture you showed us, I think it was in the first section of this. It's going to be reversed because I'm going to show it on here. But this one, I don't know if you can see that.
Yes, the dermatome.
Yes, on that, I had a question. It said, like, it has all of the vertebrae listed, but it has V1, V2, V3, as well as the C. And I don't know if that was supposed to say C. I was just
Yeah, there's
okay.
not a V1. It must have been saying like vertebra 1, but you'll never hear
Okay.
it in real life.
That I just wanted to verify. Thank you.
Yeah, thank you. All right, y'all, I just noticed that it is 10 after, and I know people may need a quick break. So let's pause there. I'll leave the slide up in case you want to look at that more, although you guys have these slides. Let's come back right at 11:15 and we will power through.
Dr. Lancaster,
Yes.
on the C5, I think you kind of explained this, but I don't really remember what you said.
That's
For
okay.
if they have no hand function, and how are they using the power wheelchair with hand controls?
So they would, because think about, if you are, I'm trying to simulate it. If you can just use it's more of a pushing, kind of a
Okay.
nudging if you're not using your hand. And you even can like open some doorknobs and things, mainly using like the back of your hand or your forearm to just nudge things. Does that make sense?
Yes, that
Not a
does.
very clinical term, but hopefully you can picture that.
Yeah.
Yeah, I was gonna say my dad has a C5, C6, C7 injury, and he can't use his fingers that well, but he can move his elbows. But he has limited range of motion in his shoulders too. But that's his
Thank
shoulder range. Yeah.
you for sharing, Caitlin. I somehow did not know that. Uh,
Hmm.
all right. So you guys, I just quickly checked my email on the break, and I don't know if you did, but the campus is closed Thursday and Friday officially per the university. So again, await instruction from other instructors as to if they're canceling or moving to Zoom. But, that's probably good news for those of you with kids who otherwise might not have anything to do with your children who are going to be out of school those days too. So we're going to be adaptable and give each other grace in this time period, but still focus on our learning. So let's keep going with this. So now we are out of the cervical range and we are more in the thoracic range, and we're going to lump together T1 through T9. Now, if you work at a rehab facility and see a lot of people with spinal cord injuries, you would know more specifically the individual levels just as part of your daily job. We're not going to get that detailed here because it's a whole lot to memorize. If you are seeing this day by day, you wouldn't have to memorize it. You would just learn it functionally. But for our purposes, we're going to group together T1 through T9. Now, here's what's important at this level. This is where the person is considered to have paraplegia instead of quadriplegia or tetraplegia in the cervical level. They have full hand and finger function at these levels, and some limited trunk control. At the lower range of this category or group, they would have stronger core muscles than at the higher levels, of course. But in general, we're just going to think of T1 through 9 as limited trunk control. The people at this level are independent in their ADLs. They are very efficient at using manual wheelchair. At the lower levels, may be able to stand with braces on their legs to kind of provide that sort of propping support. But primarily, they're still going to use a wheelchair for mobility. Now, really, really important that you remember that at the specific level of T6, that is a key level because it relates to two things that we've talked about as potential medical complications or emergencies, and that is orthostatic hypotension and autonomic dysreflexia. The risk for those two things starts at T6. So remember that. But you're seeing beyond the cervical region, you're seeing much more function in people. Now let's go at the very bottom of the thoracic into the top of the lumbar region. So T10 to L1. good trunk control, better balance, lower extremities are still weak. So we say that the lower extremities still have paralysis and the person is still has paraplegia, but it's because of weakness, not complete inability to move. So a person at T10 to L1 might even be able to walk short distances with braces and assistive mobility devices like a walker or crutches. Now, this is going to be after they have been to rehab and with continuous workouts for that. They may use a wheelchair for long distances, and that is due to endurance. It just takes a lot of energy to do that walking, even with assistive devices and leg braces. And so they may opt to have a lightweight manual wheelchair, but they're really independent in ADLs at this level. Now let's get down to the bottom of things with L2 to S5. So most of the lumbar and all of the sacral section of the spinal cord, that people are much better at walking with braces or and walker and or maybe even like a quad cane. Better control of lower extremities and hips. They may still have some bladder and bowel control depending on the level of injury. If it's very low, they may have some control. And they are more independent in mobility, and some individuals can even, at the very low level, can even walk without any device use. So that's the low, low levels. So the most complicated really to remember, a little bit here, remember this is where paraplegia starts in the thoracic level. Independent in ADLs may start standing, but and really remember that T6 level, but then your cervical levels are the more detailed ones. So hopefully that helps. The function of that relating to that. Yes, Lizzie.
Coach Allen was a T6 7
Yeah, I think he said T7, but somewhere right in there. Yeah.
because he had he was in his wheelchair with no use of his legs that I can remember him saying, but his upper half was totally like functional.
Yeah. So the tricky word there is use of, because if he did not seem to have much voluntary movement in his legs, but we didn't test him, of course, it's possible that he would be able to transfer himself over, maybe using a sliding board to another surface and then lean his knees in that direction. And then most likely he's going to use his upper extremities to move his lower extremities over. So, there is a great degree of weakness, and that's still considered paralysis technically, but they may have a little bit of movement in the lower extremities there.
Okay, thank you.
Let's talk about a type of spinal cord injury called transverse myelitis. Now, this one's a little bit unique because it is related to inflammation. And so I looked up on the internet. I was really looking for a photo that would show a scan of what this looked like, and I had a kind of hard time finding it, but this might this is from somebody with transverse myelitis. It's probably 1, 2, 3, 4, 5, C6 area there, as it's shown. But know that it's due to inflammation of the meninges and other tissues that put so much pressure on the spinal cord that it can result in a permanent spinal cord injury. And so notice what I put on the slide, the myelin sheath, remember that protective covering of the brain and spinal cord is damaged and causes paralysis below the level of inflammation. So in this scan, below C6, and because it's inflammation, it's happening over time. So it can progress over days and sometimes even weeks. Now, if somebody has transverse myelitis, and I'm going to give you an example of someone you're already familiar with that has this condition, that's a specific type or cause of a spinal cord injury. About 1/3 of people with that fully recover when the inflammation subsides. It's not that their spinal cord has regenerated or it hasn't been neuroplasticity, any of that. It's that the pressure was temporary, and when that resolved, the cord is no longer being compressed. So about 1/3 fully recover, about 1/3 partially recover, and then about 1/3 demonstrate no recovery after that injury, depending on how much the swelling was, and whether or not the cord was compressed fully or not. Wesley, do you want to add to that?
I was just gonna ask, you said can result in permanent, what did you say? Permanent.
Paralysis, so loss of movement and sensation.
Okay.
For some people, that injury is incomplete. For some, it is complete, just depending on how bad the inflammation was and where it was. So this shows the C6 level, but it can be further down. So the person I'm referencing that you're already familiar with, whose injury happened due to transverse myelitis, is Alicia. We've seen her in a video, and I think she has a really good way of explaining things. And her blog, if you're interested, is aliciareagan.com. But what happened with her is that back in 2009, she was actually pregnant with her sixth child, and she just, from some rare reason, got that inflammation in her spinal column that resulted in transverse myelitis. Now hers is lower than the cervical level. She is, I don't remember if she said her exact level, but she has said that she has paralysis from the rib level down. Now, with her, she does have what we think of as spasticity. And so that's extra muscle tension. We're going to talk about what that is more in detail but know in just a second. But know that it is a side effect of paralysis that can vary from being some mild muscle stiffness to severe, uncontrollable extra tone or tension in the muscles. So that condition in its extreme form is called spastic hypertension or spastic hypertonia. Either one. And that can occur from a spinal cord injury or some other neurological conditions, like a brain injury or multiple sclerosis, which we'll be studying very soon. So let's talk about spasticity a little more. Spasticity after spinal cord injury can be painful or irritating if the person has sensation, and it can limit somebody's ability to perform tasks in a functional manner, such as being able to do lower body dressing. If it is somebody that needs to wear like a Depends or a brief, it can be very hard for their caregiver to change them in that way if they are really tight in that area, even if it is a short-term temporary, spastic reaction. So spasticity is a side effect of paralysis that varies from mild to very severe. It's not voluntary. It can cause the lower extremities to cross or jerk up in a way. It's not harmful in that it's not, going to stay that way long term. It doesn't always need to be treated. And that's something I um, didn't really learn until I was out in the field working with people with spinal cord injury, is that some people with a spinal cord injury actually use their spasticity to help them get some kind of movement to be more functional. And I'm going to show you a video in just a minute, but problems that can result from spasticity is a loss of range of motion temporarily. It can make driving, if they are in the level that driving with an adaptive vehicle is possible, it can make that dangerous or just really challenging. Um, it does put them at increased risk for fall. So it looks like a jerking of one muscle or a limb or a part of the body. Most people who have spinal cord injuries live with some degree of spasticity or muscle spasms. People with higher level injuries like cervical level and people with incomplete injuries are more likely than people with paraplegia or complete injuries that would have them have flaccidity or loss of muscle tone. Now, this is important. The most common muscles that tend to spasm for someone with spasticity are elbow flexors and leg extensors. Elbow flexors and leg extensors. And those spastic responses usually happen in result of a certain type of movement of the limb, if someone positions it in a certain way, or pain. So how do people deal with spasticity? Regular stretching, weight bearing, and that's a very important way. So if somebody's leg is spasming, if they are having spasticity in their leg, if weight can be put through that ankle and knee, even if they're pressing with their upper extremities or if somebody else is doing that, then the spasticity will subside. Sometimes temperature, like the use of hot or cold packs, can help that spasticity subside. Now, it's very, very important that that you be specifically trained in that and really monitor it closely, because the person is going to have decreased or absent sensation and they won't be able to tell you if it's too hot or too cold. Many people with spinal cord injury are on medications that help control spasticity. And an example of a medication would be baclofen, and that's the brand name. Sometimes people will be on Valium for that, or another type of muscle relaxant like Flexeril. I won't ask you those specific things, but you may see that in charts and hear that discussed. Sometimes people will get Botox injections into a part of their body, like their leg, like their hamstrings, to relax it so that spasticity doesn't interfere with their function. Back many years ago, probably like 30, when I was working at Le Bonheur, and working with people with spinal cord injuries, even back then, Botox injections into especially the lower extremities to help treat spasticity was very common. So I know that a lot of people use Botox for cosmetic reasons now, but it's been around for decades as a use with the use of treating spasticity. And there are some surgical options, and you may hear about and see that in the field. One might be inserting a little pump. It looks kind of like a hockey puck under the skin that delivers medication to help the muscles relax. And they might even cut the nerve roots surgically to keep any remaining nerves from doing what they're supposed to if they are having a lot of spasticity that's interfering with functions. So positioning, this is important for you to know. Positioning as a treatment or way of responding to spasticity. The main thing you need to know about that is it will help to avoid spasticity or to address it if it is happening for a person, if their lower body is positioned in what we think of as a 90-90-90. So that means 90 degrees at the hips. So notice the way this person's rear end is all the way at the back of their wheelchair seat. And so their hips are at 90 degrees. You can't see it so much on this slide, but maybe a little bit. Their knees are also about at 90 degrees. Their legs aren't up on the footrests or too far, more than 90. And their ankles are also at 90. So 90 through the hips, 90 through the knees, and 90 through the ankles. And that will help with spasticity. Now let's go on and talk about something else that you may see if you work with people with spinal cord injury, and that's something called the halo or the halo vest. Now, there's more information I wanted to call your attention to in the acute care textbook, starting on page 515, but I wanted to show you what that looked like. This is something that is actually affixed to the skull temporarily after cervical level injuries to the spinal bones. And the reason is because those bones need to stay in place to avoid more injury to the spinal cord. And if it's a really high injury, it helps it gives the spine time to heal after a fracture or some sort of other injury to the cervical level spine. So fixation, if you look really closely, you can see those metal pins through the skull so that it's done, under sedation. It sounds pretty brutal, but I'm told that it isn't. They numb that up and the person's under sedation and they put titanium pins into their skull and then they affix this sort of cage, the halo, to those points. And then they have on this softer vest down below. And you can see how the rods go in there. Most people who have a halo and are wearing that for usually 8 to 12 weeks while their spine heals, they report that it doesn't cause them pain. They do need to do some wound care, put some ointment around the screws every day to keep the skin from growing to that area. And usually this is worn for about 3 months. Now, a couple of important things to note. If you are working with somebody who has a halo, is it will make them very top heavy. Now back when I first started working with people with spinal cord injuries, I actually, no one told me that in OT school, and I did not know until I went out on a level 2 field work and started working with a client who had a halo on. And it was in an inpatient rehab facility, and this was a very tall guy, like well over 6 feet. And so the body mechanics were tricky. When I helped him go from lying in the hospital bed to sitting on the edge of the bed, it surprised me a little bit how wobbly he was, because of his paralysis, but also because of the weight on his head and neck. So just be prepared for that. Know that they are lighter weight now, but they still do weigh several pounds. And can, especially if somebody has weakness because they are paralyzed, it can cause them to be very off balance. So their center of gravity and coordination may be compromised. Sponge baths have to be used. This cannot get submerged in water like in a tub or shower. Generally, their clothing, they'll figure out ways to put things up under it or over it. Whether it's Velcro or snaps or zips. One thing that I also didn't know until I got out in the field was that a child who is wearing a halo vest will need a larger than usual size car seat if they are of the age or size that requires a car seat. So they're going to have to go up a size so that it really can contain that apparatus. Now, somebody who doesn't have to be in a car seat can just use a regular seat belt in the car. Any questions about the halo? think I might have a comment. Does it leave scars on the head? Oftentimes it does. They are very tiny and over time really fade, but if you know to look for it, you can notice it. All right, so let's pause there, and we're going to come back to this at the lab tomorrow. But I want to play a Kahoot to kind of solidify some of this knowledge. Let me.
Dr. Lancaster,
Yes.
when you were talking about the spasticity, you said that they will have issues with elbow flexors and leg extensors.
Yes. Yes, exactly.
Okay. And then Alicia, her condition, her situation was non-traumatic because it
Yes.
was due to pregnancy.
Due to swelling that happened as a result of
Okay.
pregnancy. And that's very rare. I don't want to scare
Gotcha.
anybody, but that is what happened with her.
Gotcha.
Not
I have a
what
question. I'm
you
sorry.
commonly see. Yes.
Yes, okay. For the Halo vest, can I get damaged? Like, can it like I don't know, get affected? I don't know how to explain it, but if it gets damaged, can it affect like other parts of the spinal cord if it's not completely, I don't know. If
Yes.
you understand
So
what I'm
let's
saying.
say somebody bumped it really hard.
Yes,
If they were
yes.
in a car accident, that kind of
Mm-hmm.
makes you want to cringe to think about that
Yeah.
happening. So if their head and neck did not stay stabilized, they could refracture their neck and further damage their spinal cord. It's very securely fixed, but it could happen. So people are cautioned to, not be in a car too much and be very careful. And, they generally will have to figure out how to sleep and how to sit even with it because again, it's heavy. And sometimes people who do not have a spinal cord injury, they just have a fracture of their vertebra, but they're at high risk of spinal cord injury, will have a halo for a couple or a few months. So you may see that out there. All right, let's play a Kahoot. Let me share my screen for this one. Here we go. So you can play it right there on your computer. Come on, come on. Or on your phone. There we go. And our game pin is 5697830. 5697830.
Can you say the pin one more time?
Yes, it's 5697830.
Thank you.
Dr. I have a question. I know at the beginning of the class you mentioned how we are going to have our quiz, and I noticed on Blackboard it was going to be online anyways, I think, but is it due tomorrow or on Friday?
We will actually take the quiz when we are online together tomorrow.
Okay.
And it will only cover content that we have talked to up till today. What else is in the slide deck and in the reading after what we've talked about, that will not be on there. I'll make sure there are not questions about that.
And so we'll have lab and class for the quiz at 1:30 or whatever time it is, 1:30.
Yes. Plan to be together just like we are now from 1:30 to 3 tomorrow. I'll write all that down on the course site and the schedule and team up when we get out of this. All right, let's go ahead and start. Here we go. Which of the following is least likely to be a good match for someone who has a C7 level injury? Least likely to be a good match. All right. So if you said a speech generating device, why did you say that? Why is that correct?
I said speech generating device because they are still able to communicate.
Yes, exactly right. Because they won't need it. They'll just talk. Good. All right. What is the spinal cord level at which strong tenodesis is first available? You can see that person using it. Good. C6. What should be done first if a client with a spinal cord injury has bradycardia, sweating, and increased spasticity? What's the first thing you're going to do? Elevate their head. Yep. So if this were on a quiz or test, I would also say to make sure you know they also have increased blood pressure. But in real life, you might just note, they might just be sweating and you might notice some increased spasticity. And then you would think to check their blood pressure and elevate the head. If the blood pressure is up, the head goes up. What's the most common type of specific incomplete spinal cord lesion? It's often linked to spinal stenosis or degeneration of the spine. Most common. Yep, central cord. Just remember, central, so it's very popular. It's the most common. And that's when the center part has a different, is as opposed to the outer part. That's where the incomplete comes in. What is absent in cases of complete spinal cord injuries? What's missing? Good. Most people got it. So the question was a little bit weirdly worded. I think I really probably should have said what is available or present in complete spinal cord injuries, in which case it would be neither motor or sensory abilities. This is a little bit of a double negative, but if we're saying what is missing, what is absent with a complete injury, we know they do not have motor ability, they do not have sensory ability. Multi-select. What is determined through assessment using the Asia Impairment Scale? Good. Most people got it. So that's the one assessment we've really gone into, and we're going to go into another one tomorrow. But what the Asia looks at, starting as soon as that spinal shock wears off, is what is their level of injury and is it complete or not? That's the one with all the little tiny check boxes. It looks like a grid that you go through and test motor function and sensory function at each of the levels to see, is it complete or incomplete, and what is the level of the injury? What often impairs function beyond the level of the lesion just after somebody has a spinal cord injury? Most people got it. That is neurogenic or spinal shock. That's when the central nervous system is trying to figure out what is going on in the days after injury. Dizziness, paleness, blurred vision, excessive sweating above the lesion, and even fainting. What does that indicate? So the dizziness, paleness, fainting, that's orthostatic hypotension. Autonomic dysreflexia is flushed face, and increased blood pressure and headache. At what spinal cord level does an injury result in an inability to breathe on one's own? Good. Most people got it. C3. There is no point at which somebody with a complete C3 or above can breathe unassisted without a ventilator. Cabrina?
I had a question on the orthostatic one. The excessive sweating, I thought that was for the autonomic. I didn't think that was for the orthostatic
That oddly happens
hypertension.
with both of those.
Oh, interesting. Okay.
Yeah, if you've ever, even with a working, spinal cord, or nervous system, if you've ever fainted, sometimes people will, it's almost like when you're nauseous and you'll sometimes get a little clammy or sweaty. It looks and kind of feels like that. So the sweating above the level can happen with either of those two things, but if they lose color in their face, their skin color is paler, if their blood pressure goes down, if they're dizzy, and if they faint, that is almost for certain orthostatic hypotension. Leah?
I was gonna ask, I know that the C4 like nerves go to the front or like they turn into the phrenic nerve, which innervates the diaphragm. So would that not also result in an inability to breathe?
Well, they have some of the what's called accessory muscles that in the shoulders and back that can support with that, but it's weak. So that's why it's very intermittent at C4.
Okay. And so for those muscles that you're talking about, is that the intercostal muscles?
Not
Or
yet.
that's up in the, you said it's up in the shoulders.
Yes, yes. So think about almost kind of if you raise your shoulders a little bit, it helps to expand the chest area, even if you're not, I mean, it's hard to isolate what we're moving, but that's kind of how it looks like. You can see them kind of breathing high in their chest, very high.
Thank you.
Good, good. All right. Next one. What term describes a fluid accumulation in the interstitial tissue, so between the skin and something else? Good. That is called edema. At what spinal cord level can someone usually begin using a hand-controlled wheelchair, power chair, like this? But C5, it's going to be very much just them kind of nudging or shoving that control. They would not need to have finger movement there. All right, last one. At what level is tenodesis available, even though it will likely be weak? So it's very first available at all. Yep, C6. All right, here is our winner board. Anybody's wondering. All right. So I will have another Kahoot for you. I'll post that link. I'm gonna write myself a note on the in the course content folder if you want to go back through it. But do look at those levels and function. We actually, now that I think about it, we may need to meet until 3:30 tomorrow. So 1:30 to 3:30 instead of the 2-hour lab. We're gonna have that was kind of staggered. We'll just do it all together, and we should get through all this content and have a guest speaker that's going to demo a very high-tech feeding device that's switch operated. Any questions for me before we adjourn for today?
So the quiz will be tomorrow.
Yes, yes.
Okay.
We will take it right at 1:30, and then we'll do what we can until the speaker joins us at 2. Cabrina, I think I saw your hand.
I was just curious if you knew if they were doing peds tomorrow. I know they canceled for today. I hadn't seen a message. I just was curious if you had an
I
idea.
haven't either, but we're about to go in faculty meeting in
Okay.
6 minutes. So I imagine just after that, it'll all be come out. But the campus is closed, so I'll tell you that. So you know you won't be going to campus. It'll either be Zoom or canceled. All right, everybody hang in there, stay warm. If you have to get out, be very careful, and I will see y'all tomorrow at 1:30. Let me know if you need me for anything.
Now say bye.
Ah!